I'll be discussing malignant hyperthermia. MH is a very rare problem that we see in anesthesia, but as it carries with it a very potentially high morbidity and mortality, it's very important for us to all be experts in it. Here on this first slide, I note that it might not actually be such a hot topic since, as we'll discuss, MH is actually a syndrome with a spectrum of presentations, of which hyperthermia is not necessarily pathognomonic. So I have no disclosures. The story of malignant hyperthermia starts out in April 8th, 1960 in Melbourne, Australia. Roy Evans, a 21-year-old engineering student, was hit by a car and presented to Royal Melbourne Hospital for a tib-fib fracture repair. On arrival to the hospital, he was more concerned about the anesthetic than he was about the fracture repair, since 10 of his close relatives had died in the past under anesthesia, mostly from minor procedures. The anesthesiologist assigned to his case was Dr. James Dermot Villiers, and he hypothesized that the relatives had died of something called ether convulsions. He therefore avoided ether and instead used thiopental and halothane on Mr. Evans. Not long after induction, the patient became hypotensive and tachycardic, the soda line became exhausted, and the patient became febrile. There had been some blood loss during the case, so Dr. Villiers gave Evans a blood transfusion and packed him in ice. About an hour after the event, the patient was awake, alert, and doing okay. He's the first known patient to survive an MH attack and subsequently survived many uneventful anesthetics in the future under spinal anesthesia for kidney stones. Not long after Evans's anesthetic, a little closer to home, a similar event occurred in actually my hometown of Wausau, Wisconsin. Mary Handrick was a 25-year-old female who was hit by a car and suffered a kneecap fracture. After induction, she experienced fever, muscle spasms, and Dr. Loker, an anesthesiologist in the area, was called in for help. He ordered the anesthetic to be stopped and the patient to be packed in ice, and she died less than an hour later. In an interview last summer at the age of 88, Dr. Loker stated that the event was quote-unquote panic inciting and made him determined never to watch another patient succumb to MH. He subsequently spent about 2 decades of his life researching the epidemiology of MH in central Wisconsin and composing a list of greater than 60 family names in Marathon County associated with the condition. Most of these names were tied to ancestors who came from Germany, Poland, and Czechoslovakia. He eventually had a giant chart of over 200 patient names on a roll of butcher paper, which they kept in the OR near the kiddie pool and the ice. He stated, quote, "We didn't have a sophisticated plan, don't get me wrong. No one has died of MH in Wausau since then." On this slide, you'll see Dr. Loker's list. Of these 62 names having grown up in Wausau, I know people with 15 of them. And you'll notice Dr. Gassner's family name is on the list also. So as an overview, MH is an extremely broad topic, and unfortunately we only have so much time this morning. So please at the end, feel free to ask me any questions if you have any, if there's anything I wasn't able to cover. Oops. First of all, what is MH? As I mentioned, it's a syndrome and not a disease. A syndrome is a group of signs and symptoms that occur together, and while you may see all of them in a particular event, it's possible and in fact very likely that you will not see every sign and symptom every single time, and that includes hyperthermia. MH is a pharmacogenetic condition wherein genetically predisposed individuals who are exposed to a pharmacologic trigger experience the symptom. As we all know, those typical triggers are volatile anesthetics and succinylcholine. There have, however, been some reports of other things such as heat, stress, and infection, as well as other drugs causing malignant hyperthermia, which we'll discuss later. At any rate, malignant hyperthermia susceptible individuals trigger these triggers cause deregulation of calcium from the sarcoplasmic reticulum, which lead to the signs and symptoms of malignant hyperthermia. And so what are those signs and symptoms? The MH syndrome usually starts within about the first hour of the induction, though it can happen at any time. And with the newer anesthetics, we see it typically a little later than we would with halothane. It can even occur in the recovery room or once the patient's discharged from the recovery room. The first sign is usually an increase in end-tidal CO2 despite increasing minute ventilation, and tachycardia plus or minus hypertension. Rigidity with possible masseter muscle rigidity usually occurs, and whole whole body muscle rigidity is usually considered pathognomonic for MH if the patient has neuromuscular blockade on board. Rhabdomyolysis causes dark urine from myoglobinuria and also an increased serum CK. The CK usually peaks about 14 or so hours after the start of an acute episode. And if it's true MH, you might expect to see a serum CK of greater than 20,000 within the first 24 hours. Labs demonstrate a mixed respiratory and metabolic acidosis, as well as hyperkalemia that's often associated with EKG changes and dysrhythmias. Core body temperature can rise about 1 degree Celsius every 5 minutes during an episode. Up to 45 degrees Celsius or 113 degrees Fahrenheit have been described. DIC may occur, and end organ damage occurs in the kidneys from myoglobin and in other organs from increased O2 consumption. It's very important to note that hyperkalemia is really the true issue here, not temperature in MH. The hyperkalemia is what kills patients, not hyperthermia. So the differential diagnosis for MH is very broad, and I've listed here some of the other diagnoses that you might want to consider. Since the first signs and symptoms of MH are typically an increase in CO2 despite increasing minute ventilation and tachycardia, usually the first things to be considered are inadequate anesthesia or analgesia and ineffective ventilation or exogenous sources of CO2. Time doesn't really allow us to talk about the other diagnoses here this morning, but if you have questions at the end, I'd be happy to talk about them. As far as incidence goes, MH is a very rare condition, and although it's important for all of us to understand it, it's entirely possible many of us will never see it in our career. At any rate, it does occur in all races and in all locations. The exact incidence is really dependent on the geographic prevalence of MH in the area, and Wisconsin, Nebraska, West Virginia, and Michigan have been described as having very high prevalence. In general, however, about 1 in 2,000 people have a genetic predisposition to the condition, and 1 in 5,000 peds anesthetics and 1 in 30,000 adult anesthetics may trigger. There are about 40 confirmed cases in the US per year, and about 300 to 600 probable cases per year. Though it can occur in any demographic, it tends to occur more frequently in younger males. The mortality today is about 5 to 10% from an acute MH episode, which is down from historic levels of about 80%. So what causes MH? The best model we have is in pigs who experience something called porcine stress syndrome, which is very similar to MH and is triggered by volatile anesthetics, succinylcholine, stress, and heat. In pigs, the syndrome is caused by one particular mutation in the ryanodine receptor gene, which codes for a calcium channel in muscle. It's inherited in an autosomal recessive manner in pigs. In humans, MH is usually an autosomal dominant condition, but it has incomplete penetrance and variable expressivity. So just because your father has it and you carry the gene, you may not express it yourself, or you may express it to a varying degree. In contrast to pigs, there's no single genetic defect in humans, although approximately 60% of the cases of MH are attributable to ryanodine receptor mutations on chromosome 19. As of now, there are over 300 mutations in the ryanodine receptor that have been implicated, and about 30 have been shown to be causative. Mutations in other genes, such as the dihydropyridine receptor, which is a voltage-gated calcium channel in the muscle cells, has also been implicated, as have other genes, and it's likely that there are many other loci of mutation that we aren't even aware of yet. So it's therefore a very heterogeneous condition in humans. There are a few different ways to diagnose or test for malignant hyperthermia. The most pragmatic way is really to look at a particular event and evaluate the clinical features of it. A clinical grading scale has been described, which assigns points for rigidity, rhabdomyolysis, respiratory acidosis, fever, and tachycardia, and then assigns a probability or a likelihood as to how likely the event was actually MH. In actuality, though, this scale is probably not that useful. If a child suffers masseter muscle rigidity after succinylcholine, they would score, quote unquote, somewhat less than likely MH on the grading scale, but that really wouldn't change your clinical management of the patient in the future. You probably still wouldn't give them a triggering anesthetic. What has long been considered the gold standard of testing for malignant hyperthermia is contracture testing. This is the caffeine-halothane contracture test in the US or the in vitro contracture test in in Europe. They're essentially the same thing, just with slightly different protocols. These tests are invasive and require that a muscle biopsy be taken from the thigh, and it has to be done at a testing center since it needs fresh tissue. In North America, there are 4 centers, and in the US and 1 in Canada. It's invasive, it's expensive. It usually costs between about $6,000 and $10,000 per test, and it's not covered by insurance typically. The muscle sample is attached to a strain gauge and then zapped with some electricity, and the tension's measured. The strips are then exposed to either caffeine or halothane, and the tension of those strips is then also measured. With the caffeine-halothane contracture test, it's important to note that the cutoffs for positive tests have been completely arbitrarily established, and in addition, they're not really defined in patients who have neuromuscular disease. In addition, the false positive rate for this test isn't known, and the false negative rate is both unknown and it's not ethically knowable. The test might have some utility in a research setting or in a setting where you're maybe confused about the clinical picture of a patient. But in general, it's not the most useful test. If a patient has a family member who had malignant hyperthermia and then themselves had a negative contracture test, you still wouldn't administer them a triggering anesthetic because it's just really not a very good test. Finally, genetic testing is in the process of being developed for malignant hyperthermia. There are 2 labs in the US, one of which is in Marshfield, Wisconsin, that do test for malignant hyperthermia mutations. The tests are less invasive, they just require a blood sample, and the patient doesn't have to travel to the testing center. They also tend to be less expensive. It costs about $4,000 to sequence the entire gene, $800 to look at the most common mutations, and about $200 to look at a specific mutation if a mutation in a family is known. As noted, though, this is a very genetically heterogeneous condition, so the test is not very sensitive. And even if a family member tests positive for a particular gene and your patient tests negative for the same gene, you probably don't want to give them a triggering anesthetic because it's possible that the proband had a different mutation as well that's not being tested for. So a positive test is very specific, but really a negative test doesn't tell you anything. As I mentioned a little bit earlier, there are a lot of conditions that may predispose a person to being susceptible to malignant hyperthermia. Of these, 4 have very strong evidence for association, whereas there are several that have weak evidence or just some evidence. And we'll discuss some of these shortly. As a general rule of thumb, though, if you have a patient with a neuromuscular disease, if the defect is before the neuromuscular junction, such as ALS or multiple sclerosis, the patient's likely not malignant hyperthermia susceptible. If the defect is at the neuromuscular junction or in the muscle, it's possible that the patient may be malignant hyperthermia susceptible, and you should treat them as such. As an approach to patients with conditions that may be associated with MH, where the evidence is weak, what you want to do is review the literature, consult specialists, document your consultations, discuss the plans with the patient, the family members, and the surgeons, and then document your discussions. You really have 2 priorities in this situation. The first is always patient safety, and then additionally, you want to cover your tush. Important to remember is that most people who are susceptible to malignant hyperthermia are phenotypically normal, and on average, people who trigger have had 2 uneventful anesthetics in the past. So really an uneventful anesthetic history is no consolation at all. Now to discuss some of the associated conditions in more detail. First, King-Denborough syndrome is one of these conditions that are classically associated with MH and always considered MH susceptible. The condition is rare, and it's caused by a mutation in the RYR gene that's usually sporadic and inherited sometimes in an autosomal dominant pattern. These patients tend to look like patients with Noonan syndrome and have short stature, lordosis, pectus, slow-set ears, developmental delay, and some proximal weakness from myopathy. They're always considered malignant hyperthermia susceptible, and they should always be treated with non-triggering anesthetics. 2 additional conditions that are always considered to be susceptible are central core disease and multi-mini core disease. Central core disease is an autosomal dominant ryanodine receptor condition that presents as a variably severe myopathy. If you look at the histology, these patients tend to have central cores in their muscle cells where they lack enzyme activity. Multi-mini core disease is clinically somewhat similar to central core disease. These patients have severe axial myopathy, often with respiratory, bulbar, and ocular involvement. It's a more heterogeneous condition, and it's usually inherited in an autosomal recessive pattern. Due to the mutation in central core disease, these patients are always treated as MH susceptible, and there are reports of these patients having triggered MH. There are actually no reports of multi-mini core disease patients having triggered a malignant hyperthermia reaction under anesthesia, but there's so much clinical and histologic overlap between the two conditions that both should really be treated as always being susceptible. Muscular dystrophies are an interesting condition in that some patients with them may experience a syndrome under general anesthesia that's very similar to malignant hyperthermia. Some would argue that it isn't malignant hyperthermia per se, as the mechanism may be slightly different, but really the trigger is the same, the clinical picture is the same, and the treatment's the same. So whether you want to call it a malignant hyperthermia-like condition or malignant hyperthermia is really just semantics. Muscular dystrophies are caused by X-linked recessive dystrophin mutations, and dystrophin contributes to the integrity of the sarcoplasmic reticulum. Lack of this protein causes proximal weakness, a waddling gait, and calf pseudohypertrophy. They also tend to develop cardiomyopathy and arrhythmia. In Duchenne's, the loss of this protein is complete and symptoms occur usually by age 5. In Becker's, it's a partial loss of dystrophin, and they're usually symptomatic by adolescence. There have been several case reports of volatile anesthetics causing rhabdomyolysis in these patients. It's thought that muscle membranes being frail or deranged calcium metabolism or altered membrane permeability may play a role, but it's not really known why. At any rate, the syndrome is clinically entirely similar to MH and should prompt Dantrolene administration. In addition, hyperkalemic arrest with succinylcholine in these patients is well described, and we're all familiar with that. The mechanism is likely excess potassium release from upregulation of abnormal extrajunctional receptors or rhabdomyolysis. So suck should never be given to these patients, and volatile should probably be avoided as well. Idiopathic hyperCKemia is a condition where patients have persistently elevated creatine kinase without a known cause. Most of the patients are asymptomatic or maybe minimally symptomatic, and it's an incidental finding on labs. This condition has gotten some attention lately from the MH community, as there have been some reports that it may be linked to malignant hyperthermia. For example, both Wiglinski and Malandrini showed that patients with idiopathic hyper-CK demonstrate positive contracture tests. These positive contracture tests aren't really that interesting, especially in patients who might have muscle pathology, unless they're actually linked to reports of people with this condition having MH, however. To that effect, there's a case report of an 18-year-old male who is healthy except for idiopathic hyper-CK, who underwent a SIVO anesthetic and experienced malignant hyperthermia. He received Dantrolene and ultimately recovered. So the evidence linking idiopathic hyper-CKemia with MH is still in the early stages and it's incomplete. But as Wiglinski noted in their paper, unexplained persistently elevated CK in an otherwise healthy patient should probably alert the anesthesiologist that there's a possibility for malignant hyperthermia susceptibility or an underlying myopathy. Kind of similarly to idiopathic hyper-CK, people with a history of statin myopathy have also gotten some attention from the MH community recently. In one study, 9 patients with statin myopathy underwent biopsy, and 7 out of the 9 of them had positive contracture tests. On a much larger scale, 885 patients were looked at who had varying degrees of statin-induced myopathy and were evaluated for mutations that are associated with myopathy. They were found to have ryanodine receptor mutations at a higher rate than would be expected in the general population. As with the idiopathic hyper-CK patients, this evidence is still really incomplete and in the early phases, and these studies would likely not really change your management of a patient with a history of statin myopathy, but it might heighten your vigilance. Similarly, patients who are known to be MH susceptible should not be denied treatment with statins if they have hypercholesterolemia, but they might want to be monitored a little more carefully as they're starting the therapy. Another area that's gotten some attention recently is the relationship between malignant hyperthermia exertional heat illness, and exertional rhabdomyolysis. These are all three hypermetabolic states with a high demand for ATP and cause stress on the muscle. Several studies have evaluated patients with exertional heat illness and exertional rhabdo and have shown these patients to occasionally have positive contracture tests. Wappler et al. Took these studies a little bit further and then looked at these patients for ryanodine receptor mutations, finding abnormal contracture tests in 11 out of 12 patients and ryanodine receptor mutations in 3 out of 12 patients. Again, these positive contracture test results aren't actually as interesting as cases of people with this condition triggering MH. To that effect, there's a case report of a healthy, fit 30-year-old male who required fasciotomy for compartment syndrome after sustaining rhabdomyolysis after a 2.5-mile walk. He underwent one uneventful anesthetic for the fasciotomy, and that anesthetic, they used succinylcholine and SIVO. The next day he came back to the OR for a washout and suffered a malignant hyperthermia reaction under an isoflurane anesthetic. He received Dantrolene and recovered, and 6 months later he was found to have a positive contracture test when he underwent muscle biopsy. Even more interestingly, he also underwent genetic evaluation and was found to have ryanodine receptor mutations, dihydropyridine receptor mutation, and a calsequestrin gene mutation. One topic that's frequently discussed as being related to malignant hyperthermia is masseter muscle rigidity. Transiently increased masseter muscle tension after succinylcholine is not uncommon, but true masseter muscle rigidity that's associated with malignant hyperthermia is typically described as being like jaws of steel, where you really can't open the mouth at all. O'Flynn noted that there's about a 1% incidence of masseter muscle rigidity in PEDS patients who are given halothane and succinylcholine, and they evaluated 70 PEDS patients with a history of MMR. 59% of them had positive contracture tests, and 12% of those patients had developed MH-like symptoms during their anesthetic. As far as management goes of these patients, it's really a judgment call during the anesthetic. If it's an emergency case, you likely need to continue the anesthesia, but it would be prudent to switch to a non-triggering anesthetic. If it's an elective case, you may want to stop the anesthetic and treat the patient appropriately. So as we all know, MH is typically triggered by volatile anesthetics and succinylcholine. Halothane is the typically classically described anesthetic, but all volatiles have really been shown to trigger MH. In comparison with halothane, it may be more likely to see a delayed onset in malignant hyperthermia with SIVO, isoflurane, and desflurane. Succinylcholine, I've read, may be a little less likely to cause fulminant MH than volatile anesthetics are, but really it's important to note that regardless, you don't want to give succinylcholine to a patient who's susceptible, and even if a patient only receives succinylcholine, if they're giving you symptoms that are suspicious for malignant hyperthermia, you treat them like it is malignant hyperthermia, regardless of whether they got a volatile or not. There have been several other culprits implicated in malignant hyperthermia. The most interesting of these really is heat, stress, illness, all causing quote-unquote awake malignant hyperthermia. As previously mentioned, PIGS trigger to heat and stress, and people who have a history of heat illness or exertional rhabdo may be susceptible. There are also reports, however, of people with MH susceptibility triggering to heat and stress. There have been anecdotal reports of patients triggering MH upon rewarming from cardiopulmonary bypass, even in the absence of anesthetic triggers. And it might be prudent in these patients to rewarm them slowly and stop at 36 degrees. Additionally, there have been case reports of awake MH, such as a 12-year-old male who had a previous clinical MH and then later suffered a lethal hypermetabolic event after a football game in 80-degree weather, and he passed away from that. Similarly, Groom et al. Described 2 patients, both of whom had awake events triggered in response to stress and illness. Both these patients were unrelated, and they passed away from their hypermetabolic crises. And they were both found to share the same ryanodine receptor mutation. There are also several medications that I list here that have been noted to be linked to malignant hyperthermia, but the evidence for any of them is really lacking. So I think it's safe to say, as far as we know, succinylcholine and volatile anesthetics are the only drugs that trigger. As far as safe anesthetics go, really anything but volatiles and sucks, so anything listed here, to the best of our knowledge, is safe. I'd like to just briefly talk about normal muscle physiology and MH pathophysiology. In a normal muscle, an action potential comes down an axon and causes acetylcholine to be released. The acetylcholine binds to nicotinic receptors and causes the action potential to travel along the sarcolemma of the muscle. The dihydropyridine receptor, which you can see in purple, senses the voltage change and undergoes a conformational change where it contacts the ryanodine receptor in the sarcoplasmic reticulum, which is the red receptors. That causes calcium to be released into the myoplasm. Once in the myoplasm, it binds with the contractile apparatus and causes muscle contraction. New information also suggests that there may be some other sources of calcium regulation in cells, such as store-operated calcium entry and excitation-coupled calcium entry, and that these may play a role in malignant hyperthermia or in Dantrolene's mechanism of action. So the contractile apparatus is shown here. Basically, calcium binds, it causes tropomyosin to change its shape so that myosin can form a cross bridge. ATP is used, the muscle contracts, and then ATP is used to pump the calcium back into the sarcoplasmic reticulum, the muscle relaxes. In MH, volatile anesthetics plus or minus succinylcholine cause a massive release of calcium from abnormal ryanodine receptors. Abnormal dihydropyridine receptors may also be involved, and then those two other novel calcium homeostasis mechanisms, the store-operated calcium entry and excitation-coupled calcium entry, may also play a role, but it's not fully understood. Then as far as calcium deregulation goes, once that calcium is in the myoplasm, it binds to the contractile apparatus and causes rigor. The contraction requires ATP, and the hydrolysis of that in the mitochondria causes increased O2 consumption, heat production, and CO2 production. And as I mentioned, the ATP is also needed to pump the calcium back into the sarcoplasmic reticulum. Once the ATP is depleted, anaerobic metabolism starts, which causes lactate to be produced. As the CO2 and lactate accumulate, you get metabolic acidosis, and as the lack of, and once the cell runs out of energy, it essentially dies. You get rhabdomyolysis, and then you have hyperkalemia. So that's enough about physiology. To manage an acute episode of MH, the first thing you want to do is immediately stop the triggers, switch to a triggering anesthetic, and call for help. You want to tell the surgeon what's going on and stop elective procedures as soon as possible. Probably the most important thing you can do is give Dantrolene at 2.5 milligrams per kilogram. That's the initial dose, and you can repeat that until the symptoms abate. The maximum dose that's been described is 10 milligrams per kilogram. If the patient's not already intubated, you want to do that and start hyperventilating them with 100% FiO2, turning your flows up to 10 liters per minute to help flush anesthetic out of the patient and out of the system. mHouse does not recommend that you change the machine or the circuit or the CO2 absorber, but in a place like this where you might have extra experienced help, probably changing out the circuit or the CO2 absorber wouldn't hurt. You can also place something in the circuit called a vapor clean filter, which we have in the MH box, and I'll talk about shortly. You want to obtain additional access, start a central line, an Ertl line, more peripheral IVs. The patient should get a Foley and an OG tube. You need to send off labs, including an ABG, electrolytes, glucose, CK, urine and serum hemoglobin and myoglobin, coags, and lactate. You want to cool the patient, but really this shouldn't be your top priority, as cooling the patient isn't going to save them. Dantrolene and treatment of the hyperkalemia are. You want to give bicarb for acidosis, and you might even want to consider giving it empirically before your blood gas comes back. You need to treat hyperkalemia aggressively with hyperventilation, bicarb, insulin plus glucose, furosemide if the urine output's low, and possibly albuterol. You should probably reserve giving calcium for cases of life-threatening hyperkalemia, as in theory it can contribute to the MH reaction. Dysrhythmias are usually due to acidosis and hyperkalemia, and they usually respond to treatment of those things, but you can also use lidocaine, amiodarone, and beta blockers. It's important to note that you should never give calcium channel blockers in this scenario. because they cause severe hyperkalemia with dantrolene. After an acute episode, the patient should go to the ICU for at least 24 hours, where they should continue to have their vital signs monitored and their labs monitored. The half-life of dantrolene is about 4 to 8 hours, and therefore recrudescence is not uncommon. Dantrolene should really be continued in the ICU for at least 24 to 48 hours, either with bolus dosing or with infusion. After the patient recovers, you want to counsel both their family and the patient. They should be referred to mHouse. You should probably write a letter to future providers and help them get medic alert bracelets. Two areas of some current controversy in MH management include non-depolarizing neuromuscular blockers and magnesium. In pigs, complete neuromuscular blockade has been shown to either prevent malignant hyperthermia or delay its onset. In people, it's also been shown to be associated with a slower onset of MH as well as a lower peak post-op CK. It's unlikely that giving the patient a non-depolarizing neuromuscular blocker is going to prevent or treat MH, but it likely won't hurt. As far as magnesium goes, magnesium inhibits depolarization and the release of acetylcholine, and it also decreases release of calcium from the sarcoplasmic reticulum. In both pigs and humans, it's been shown that sevoflurane and halothane decrease this inhibitory response. So again, it's unlikely that giving magnesium will actually extinguish a malignant hyperthermia event, but it probably won't hurt. As far as dantrolene goes, it was first developed as an antibiotic, but it was noted to cause muscle weakness in animals. It's been available in the US for MH treatment since 1979, and it's been associated with a decrease in mortality from MH, decreasing it from 70 to 80% down to about 5 to 10%. We don't know its exact mechanism of action, but it seems to decrease calcium in the myoplasm and acts as a direct skeletal muscle relaxant. mHouse recommends that any place that's giving triggering anesthetics should have 36 vials in the house at all times. One vial contains contains exactly 20 milligrams of dantrolene. So if you have a 100-kilo person, that initial bolus is going to require 12 and a half vials. And the total 10 milligram per kilogram, quote-unquote, max dose would require 50 vials. Each vial also has 3 grams of mannitol, so if you give a patient an initial bolus of 2.5 milligrams per kilogram, they get about one-third gram per kilo of mannitol as well, which helps with diuresis in the setting of myoglobinuria. One vial costs the hospital about $65, so having 36 vials on hand at all times costs about $2,300. The shelf life is long, but once you reconstitute it, it only lasts for 6 hours. When you reconstitute it, you want to use warm water. It's been shown that the dose for a 70-kilo person takes about 15 and a half minutes to mix up if you use room temperature water, whereas it takes about 4 minutes to mix up if you use warm water. And you should use water instead of LR or bacteriostatic water, because if you use LR or bacteriostatic water, you get a cloudy, opaque precipitate like shown in the picture. Dantrolene is metabolized in the liver, and as I mentioned, its half-life is about 4 to 8 hours. It has a high pH, which is responsible for phlebitis in about 9% of administrations. The other side effects include weakness in about 20% of people, and also GI upset in about 4%. As I mentioned before, you don't want to give calcium channel blockers with this medication. We're not sure why, but it seems to cause severe hyperkalemia and cardiovascular collapse. So where can I find dantrolene? In the main OR, it's kept in the pharmacy, and you can see the warmer for the sterile water right below it. The box itself has 12 vials of dantrolene in it, but there are many more available in-house. You just need to call pharmacy and ask, and they'll bring it to you. Aside from dantrolene, the box contains bicarb, D50, Lasix, and calcium. You'd need to grab insulin from the fridge, and you'd also want to grab a cardiac box. And then in outpatient, the box is also in the pharmacy. The sterile water is in the OR hallway in a warmer. And then at Children's, both the box and the water are in the pharmacy. So for a known malignant hyperthermia patient, you want to err on the side of caution, and you want to be very vigilant. The first thing you want to do is, quote-unquote, clean the anesthesia machine, which we'll talk about in a moment. And then you want to plan a non-triggering anesthetic. As long as you take these steps, patients don't require dantrolene prophylaxis. That used to be recommended in the past, but it's not any longer. You want to have the malignant hyperthermia box in the room, the crash cart nearby, and all triggers out of the room, such as succinylcholine and the vaporizers. You need to make sure that everyone is on the same page, the surgeons, the nurses, perfusionists, and you want to make sure that the PACU is aware too. If you're in the heart room, make sure the perfusionist takes the vaporizer off the bypass pump. And you want to make sure the PACU knows so that they're increasingly vigilant also for signs of post-op MH. And so that patients aren't given succinylcholine if they need to be re-intubated. In OB, if the baby's father is susceptible, the baby might be, and so you should treat the mom as susceptible also. Volatile anesthetics cross the placenta, but very little succinylcholine crosses the placenta. Some experts would say that you can give succinylcholine to a mom who has a possibly susceptible baby. Others would say absolutely not. Really with succinylcholine, you just need to weigh the pluses and the minuses of a potentially difficult airway versus the baby potentially triggering. Dantrolene also crosses the placenta. It's considered to be pregnancy class C. It's been shown to kill rabbit and rat pups when given in very high doses. In humans, you'd expect the baby to be somewhat weak, but of course, if the mom is triggering malignant hyperthermia, you want to give dantrolene anyway. As far as cleaning the machine goes, it's important to note that we don't know what the safe concentration of volatile anesthetic is to give to someone who's susceptible. 5 parts per million is talked about as being the generally accepted level, but there's no evidence for that at all. OSHA states we need less than 2 parts per million as far as an acceptable occupational exposure goes, but likely during a PEDS inhalational induction, we're transiently exposed to higher doses than that. There are no case reports in the literature of people who work in the operating rooms triggering malignant hyperthermia from environmental exposures. As far as preparing the machine goes, MHouse recommends you talk to the machine manufacturers. The machine manufacturers don't have any recommendations, probably because it's a litigious subject. Brunner et al. Looked at 8 Avance anesthesia machines, which are the ones we have in children's and the main OR, and also 1 Amingo machine, which is apparently similar. They took machines that have been used all day in the OR with SIVO and then measured the SIVO concentration as they flushed it. The initial concentration in the machines was approximately 30 parts per million. After a 10-minute, 10 liter per minute flush, the median concentration was about 2 parts per million. And after 22 minutes, all machines were significantly less than 5 parts per million. The vapor clean filter is something that we have in the malignant hyperthermia box. It's an activated charcoal filter that you can place in the circuit. It's been shown to decrease volatile anesthetic concentrations to less than 5 parts per million in less than 2 minutes, and that effect's been shown to last for 60 minutes. They cost about $80 each, and they're in the MH box. Here, it's not recommended that you use it for prophylaxis if a patient's susceptible. Rather, it's recommended you put it in the circuit if a patient triggers. And speaking of at UW, our wiki recommends removing the vaporizers, doing a leak test, flushing the circuit for 10 minutes at 10 liters per minute, and then checking the circuit with a gas analyzer to make sure there's no residual anesthetic. It's not necessary to replace the CO2 absorber or the bellows, as neither of those have been shown to influence the washout rate. So finally, as a take-home message, MH is a fortunately very rare condition, but as anesthesia providers, we all need to be very familiar with its rapid detection and treatment. It's important to remember that it's a syndrome and not a disease. You might not see every sign or symptom every time. Furthermore, an increase in end-tidal CO2 accompanied by unexplained tachycardia is usually the first sign, not an increase in temperature. You want to always be vigilant and have a low threshold for suspicion if you think that something's not right with your patient. It's important to remember that most individuals who are MH susceptible are phenotypically normal, and most have had prior uneventful anesthetics and may not have a family history of anesthesia problems either. If the patient has a neuromuscular condition and it occurs before the neuromuscular junction, they're probably not susceptible, but if it occurs at or in the muscle, then they should be treated as susceptible. And remember, it's not typically hyperthermia that kills a patient, it's hyperkalemia. So prompt administration of Dantrolene and treatment of the acidosis and hyperkalemia are the most important things you can do. I'd like to thank Dr. Hogan, Dr. Woolman, and Dr. Benka for helping me. All right, any questions?